Good morning. I'm Vivek. Mathew. I'm a neurophysician. I'm from the Department of Neurology in the Ranipet campus. And I was initially wondering why I was asked to introduce Sir, but I bring a slightly different perspective, which is also useful to you. So Sir is going to speak to us about 4 decades of research at CMC Vellore on neurocysticercosis and the interdisciplinary transnational nature of this collaboration. 40 years, of which 50 years he's been in Vellore. He's from the 1975 batch. 40 years in one's field shows what? Perseveration, focus, commitment. Neurocysticercosis is just one of the many areas that he has delved in. I don't have time to go through all the areas that are listed in his biographies. Multiple disciplines, multiple institutions, multiple countries that he has collaborated with. So I'd just like to quote from his own article. He wrote in Neurosurgery, A Legacy of Excellence. Neurosurgeons are often identified with traits such as arrogance and hubris. However, their true legacy is excellence. True excellence. And this he will show to you how it happens. Cycles of clinical question, research method, publish, review, validate, develop algorithms, collaborate, and finally, change of practice. And this is where I can bring a little bit of a different perspective. I've been with this institution just under 20 years, and during these 20 years, I've been able to watch him closer. But when I joined for my medicine at MD Medicine at Indore, which is a remote place in North India, Madhya Pradesh, at that time, we were stopping anti-tubercular medications for single ring enhancing lesions because the practice at that time was any ring enhancing lesion is TB. Our HOD at that time told us that it was due to work done in Vellore to minimally invasive and stereotactic biopsies. It was shown that most of these ring enhancing lesions are cysticercosis. 23 years back, when I joined for my neurology training in Jaipur, again, North India, we were stopping albendazole for some of the patients with cysticercosis. Again, I learned that all patients with NCC do not need antihelminthics. In some, it is even dangerous. Even if we start with steroids, practice change. Again, our then HOD asked us to look at the guidelines. And these guidelines were the contribution from India was mainly from Vellore. So when I finally did join Vellore in late 2006, I realized that Dr. VR, who at that time was still in his 40s, had already been founder, secretary, and treasurer of the Indian Society of Stereotactic and Functional Neurosurgery. He, from 94 to 2000, he went on to become the president of the same, and he also went on to become the president of the Neurological Society of India, the NSI. He has been on WHO panels for developing guidelines on terminology, diagnosis, and management of neurocysticercosis in South America with his colleagues in South America. All this over these last 40 years. He has been the recipient of a major grant, what we call as an RON from the NIH, National Institute of Health in the USA, for $3 million US, which over 2018 to 2023 to study the immunological aspects of neurocysticercosis. So as you can see, it is indeed a privilege to hear from a dear Dr. P. Rajshekhar on 4 decades of research in neurocysticercosis at CMC, a story of interdisciplinary and transnational collaboration. It is going to be a fantastic journey that we'll be listening to from the person involved himself. Thank you.
Good morning. Thank you, Vivek, for those kind words of introduction, especially giving your personal perspective to our work. I think that lends meaning to what we have done in the field of neurocysticercosis. Of course, I need to thank Nihal for giving me this opportunity to share with you this. I would say it's not just a personal journey, it's a journey that the department has undertaken along with several other departments in the institution. So that's what I want to share with you. Basically, the thrust of my presentation today is to showcase the opportunities that exist at the Christian Medical College Vellore. And I just cannot but thank God that I have got this opportunity to work in this fantastic institution for close to 50 years. It's almost 50 years, 2 months from now. I joined CMC in July 1975. So just a couple of months away, I'll be 50 years here. And I'm grateful to God for giving me this opportunity. And I just want you to also realize, those of you who are a part of this institution, that the sky is the limit. So when I started neurosurgery in 1982, I joined the department in 1982. The first year I spent in general surgery. And Nihal, by the way, how much time do I have? I can take the whole day telling you the story, but anyway. So, okay, I'll take about 40 minutes or so. Okay. So by 1985, CMC got its CT scanner. But even prior to that, we were seeing patients with CT scans done in Chennai. Chennai had got its first CT scanner in 1982. But the first CT scanner in the country came to All India Institute of Medical Sciences in New Delhi in 1979. So they had the opportunity to study intracranial pathology, which was not prevalent in the developed world. And so they had the opportunity to put labels onto things that they were seeing. So imagine a situation, and this is just not imagination, this is true. This used to happen day in and day out, believe me. We used to see young patients who used to come to our emergency room with seizures, just a short duration, a few days at most. And they just had no other neurological impairment. And by 1985, like I said, we already had our CT scanner. So we sent them for a CT scan. And this is what we used to typically see. This is this is just about a centimeter in size, enhancing. That means you give contrast injection to these patients. So it's enhancing. The white part is the enhancement lesion. And what you see as black around it is the edema. Edema is nothing but brain swelling that has occurred around the lesion. So we used to see this, and we had no doubt what it was. We said, this is tuberculosis. We should start them on anti-tuberculous therapy and tell the patient you'll be okay, anti-epileptic drugs, of course, and say that you just come back up to us after 3 or 6 months and we'll repeat a scan and then decide what is done. And why did we do that? The reason we did that was because of this study from the All India Institute, which was published in 1980, which illustrated lesions like this and said these were immature tuberculomas or microtuberculomas. We had no reason not to believe them, because once we gave anti-tuberculous therapy to these patients like they did and repeated a scan after 3 or 6 months, the lesion was gone. So there was the proof. A therapeutic trial proved the diagnosis. But there is a major flaw in that line of reasoning. I'll come to that shortly. And that flaw in that reasoning was brought about by these authors, who in 1985 described a series of 11 patients, if I remember correctly. They were from the Army Hospital in Delhi, to whom they gave anti-tuberculous therapy. Patients took them for a few days. And you know what happens with anti-tuberculous therapy? You get nausea, you get vomiting, you have abdominal discomfort, and so on and so forth. Patients just didn't bother to take it. They came back after 3 months and told these neurologists and neurosurgeons that here, these are the medicines that you gave us. We couldn't tolerate it. Take it back. But we are fine. And they said, okay, let us see if you're fine. So they repeated a scan, and lo and behold, the lesion had gone. So which tuberculoma disappears on its own? It doesn't. So they raised the first suspicion that these are not tuberculomas, but they couldn't tell us what they were. They said these probably are not tuberculomas. And we also latched on to that. We said, okay, let us not give them a label. Just let us give them a label that fits the description of, it's just a description of what they are. So we call them single because they were solitary, small, less than 1 centimeter, enhancing because they enhance with contrast, CT because it's on the computerized tomography, and a lesion. That's all we call them. We said we will use this acronym SSECTL. In 1988, we coined that term, but we didn't know what the etiology was. We said we are not going to guess. This is unlikely to be tuberculoma because it is. But the problem is that most neurologists and neurosurgeons in the country were unwilling to accept that these were not tuberculomas. So you have this paper in 1987 from a group in Pune. Dr. Avadia is a respected neurologist in the country. In the conclusion of the paper, look what he says. Though not histologically verified, it seems justified that a third or probably more of these lesions are tuberculosis. So we said we need to get a definitive diagnosis. So we did what are called as stereotactic biopsies. That is, we took out small bits of these lesions. And the pathologist, who was Dr. Sushil Chandy at that time, told us, no, you're just getting some inflammation. I can't tell you the etiology, why these lesions, I mean, what is causing these lesions. All that I can tell you, these are inflammatory lesions. So he told us we need to remove this completely. And the reason we were able to do this biopsies was thanks to this man, my mentor, my teacher, Professor Mathew, late Professor Mathew, who, as he retired in 1986, through an ASHA grant, ordered us this apparatus called the Brown-Roberts-Wells stereotactic system. So we were the first in the country in 1986 to get hold of this stereotactic system. And what it does is that it leads you to these small lesions in the brain. You don't need to explore a big area of the brain. And even if you explored it, you couldn't find it because these lesions were so small and subcortical. That means when you see the cortex of the brain, you don't see the lesions. You don't know where you are. So you're digging in, and it's not a good idea to dig into somebody's brain. You make them hemiplegic, believe me. So when we got this apparatus, we said, now we have this opportunity to study these. And that's what we did. So we took out these lesions in 15 patients. I still remember the excitement when Dr. Sushil Chandy rang us up after I took out the first lesion in 1988. And he said, Rajshekhar, I'm seeing a cysticercal lesion very much like this. This is a part of a cysticercus within the granuloma. And then sort of suddenly it hit me that, okay, went and discussed with Dr. Mathew Chandy and Dr. Jacob Abraham and others, and they said, maybe cysticercosis, but we were not aware that they resolved spontaneously. So that there is the flaw in this belief that the therapeutic trial with anti-tuberculous therapy proved that they were tuberculomas. They were not tuberculomas because they were disappearing spontaneously, not due to the anti-tuberculous therapy. So that's a very important lesson to learn and keep in mind when you think that, the therapeutic trial has proven that whatever you're treating for is the pathology. It may not be. It may be something else. It may be spontaneous resolution. It may be the steroids that you're giving along with your specific therapy that may be causing it to resolve. And we published this letter in Lancet, which showed that 12 of the 15 biopsies showed a cysticercosis and 3 others showed inflammation, but no tuberculomas. And I still remember, I don't know if Sir remembers, Dr. Jacob John. I went to him with this. Dr. Jacob Abraham suggested that we publish this somewhere, which is a prominent journal. And I took the manuscript to him, and he also vetted it. He said, yeah, this you can submit to Lancet. And that's how this letter appeared in Lancet in 1989. But the problem, so before I go further, I suspected that a lot of you may not be familiar with what is neurocysticercosis. I don't blame you. But it is the commonest parasitic disease of the central nervous system. And it is now, of course, we know that it is the major cause of epilepsy worldwide in endemic countries. And the endemic countries that you can see, everything in red, orange are endemic countries. So most of the world, okay, most of sub-Saharan Africa, most of South America, most of Asia. So the only countries where it is not very prevalent are those in Europe. There also you have some countries where it is still there, and North America, where actually along the southern belt now, you have a lot of cysticercosis due to immigration from Latin America. So basically what happens is that humans ingest infected pork and they get this disease called teniasis. So Taenia solium, or the pork tapeworm, the reason we need to specify Taenia solium is there is another tapeworm called Taenia sarginata. That is the beef tapeworm. Beef tapeworm does not cause cysticercosis. By the way, beef tapeworm is prevalent, is rampant in Europe and North America. It's there everywhere, but it doesn't cause cysticercosis. So one doesn't have to worry about it too much. Taenia solium, on the other hand, causes teniasis, which if it just caused teniasis, we won't be worried about it. But the problem is that humans get accidentally infected with the Taenia solium eggs due to fecal contamination of food and water. And that's what leads to human cysticercosis. So it's not by design. The parasite doesn't want to go this way, because for the parasite, it's a dead end. Cysticercosis in humans is a dead end for the parasite. Parasite wants to continue the life cycle as shown here. The eggs which come out in the human feces are ingested by pigs, free-roaming pigs, especially in countries which do not have latrines. And then the infected pig, without being cooked properly or uncooked, is consumed by humans, and then the cycle continues. They get teniasis. So the human disease is of two kinds, teniasis and cysticercosis. But without teniasis, there is no completion of the life cycle in a community. So if you see any free-roaming pigs in a community, be almost sure that there is cysticercosis in the community, that there is some amount of teniasis in the community. So anywhere around, if you see free-roaming pigs, I'm quite certain there is cysticercosis there. And it's a major cause of seizures. Like I said earlier, 80% all seizures are caused by cysticercosis. That's the adult worm. This is what is in the intestine. Okay. And the cysticercus I have already shown you. Now, cysticercosis is not something that we discovered in 1989. It's something that we were familiar with in our department. It's not only in our department, in our country, but it was a forgotten disease because it's an elusive disease. Till the CT scan came, we couldn't image cysticercosis in the brain, except with plain X-rays, you could see some calcifications, but you could not see the larval form properly, like we saw on that CT scan. So you have this paper published in 1970 from our department, talking about these 25 cases of cysticercosis, 5 on autopsy, 11 on biopsy, and some in the subcutaneous nodules. That's where it goes. Other than the brain, it goes to the skin, and some showing some intestinal teniasis plus radiological changes. This is Professor Mathew, this is Professor Jacob Chandy, and that's the other author, the first author, Professor Dinakar, who went on to become the director of Nizam's Institute in Hyderabad. And I was fortunate to give an oration at the Andhra Medical College about 7 years ago in the honor of his mother, Satyavati oration. So it's not something new. And very interestingly, you see, it's not 1970, 1948. Dr. Galt published this case report, cerebral cysticercosis. So it's an ancient disease, very well known, but like I said, ignored in favor of tuberculosis. We thought that India was endemic for tuberculosis, but we forgot that this disease called cysticercosis also is very much around. So this is set the stage for the first collaboration with an international organization. And again, I don't know whether Professor Jacob John remembers this. I got this letter from CDC. In 1989, the same year we published our letter in Lancet. Those days there were no emails, no faxes, just plain regular air mails. The authors, Victor Sang, he wrote to me saying that we read with great interest this article in Lancet. We have a new test, which is basically the Western blot. It's an immunoblot. And we would like to test our new test with samples from your institution. I was just finished my neurosurgical training. So nobody had done this. And I went to Dr. Jacob Abraham. He said, if anybody knows about how to do this, it's Professor Jacob John. So go to virology, talk to him, ask him how to do it. So he warned me. Sir, I don't know whether you remember this conversation long back, 1988. So I went to him and he gave me a very important piece of advice. He said, yeah, it's good to collaborate. Send them this, but be very wary of any collaboration with anybody. You send them blinded samples. He said, don't reveal the diagnosis to them. Say, you will hold the key. And those days, it was very easy to send samples, by the way, not now, like now. So we just lyophilized it, thanks to Dr. Anna Uman in a neurochemistry lab. I just asked her, can she help? She said, yes, I'll lyophilize these samples. And 36 samples, some healthy volunteers, some cysticercosis, some healed, and so on and so forth. We labeled it and we gave it to somebody who had come for the council meeting, who had come from the United States. We just put it into a small envelope, sealed it, put the address, and asked her to post it to the US. She went to New York and posted it. And that's how the samples reached CDC. And the workers at CDC, by that time, I think Victor Sang had gone. And so we have this chap called Peter Shands. They communicated and said, see, these are the results. You break the code and tell us what is what. And we broke the code and gave them the bad news that for the solitary cysticercus granuloma, or the single enhancing lesion, only one was positive. And the calcified lesions, none. Healed or calcified lesions, none were positive. So they were very disappointed because they had shown 95% sensitivity and 100% or 98% specificity. So obviously they didn't want to air these results. So, but I insisted, I said, right, or good or bad, we need to tell the world that this is how it is. And so I had moved on to Hanover for my study leave at that time in the US. And from there, we published this short letter in the journal JNNP. So we went on to tell the world, hey, these are not tuberculomas. Don't treat them with anti-tuberculous therapy. So we said empirical anti-tuberculous therapy should be avoided. We gave a treatment algorithm. But people are loath to change what they used to doing. And so we said, unless we categorically show that tuberculomas and cysticercal lesions are different, we are not going to be able to convince the world. Because that is the bugbear. The basic problem is these are tuberculomas, is what the rest of the country is saying. We are saying these are cysticercosis. So this was the paper that really sort of changed the management and diagnosis and management of these lesions. In the sense, we give them objective criteria. So we came up with these criteria on the basis of comparing histologically proven, gold standard, histology is the gold standard. So we said we will take histologically proven solitary cysticercosis granulomas, histologically proven tuberculomas. Their clinical presentation is the same. They presented with seizures. They had a single enhancing lesion on the CT scan. So clinically, and you could not distinguish them. That's what we said at initial presentation. But actually, if you dug into their history and examination, we found that there were differences. Patients with the solitary cysticercosis granuloma do not have raised intracranial pressure, do not have progressive neurological deficit, won't have features of tuberculosis in any part of the body, and CT will have, besides being solitary and contrast enhancing, the lesion size was very important, less than 20 millimeters, and edema, which will not cause midline shift. We went on to validate these criteria in a prospective study in 401 consecutive patients. And you see that the solitary cysticercosis granuloma has very varied imaging features. This is the most characteristic. If you have a ring with a dot, the dot is the scolex. You can be more or less 100% certain that this is cysticercosis. But a lot of lesions don't have that dot. You see this, see that. This has, but these three lesions don't. So we said our diagnostic criteria are very specific, very sensitive, high positive and negative predictive values. So the story should be over. We have solved the problem. We know how to sort out TB and cysticercosis, solitary cysticercosis granuloma. So maybe we should stop our work, but that's not how it is, because cysticercosis doesn't just present with single lesions and doesn't always present with seizures. So you see, these are all patients with different kinds of cysticercosis. Some present in the brainstem, no seizures. And this is a biopsy we did because we didn't know better. We didn't know this was cysticercosis. We did a stereotactic biopsy of the brainstem. It's not a procedure to be taken lightly either by the patient or by the surgeon. But we had no choice. We didn't know what to treat this patient with. And it came out as cysticercosis, one more lesion, multiple lesions. Of course, here the scolex gives away the diagnosis. Sometimes they present with just severe headache. So we realized that just having a diagnostic criteria are not enough. We need a serological test after the imaging, because clinical features don't tell you what the disease is. Multiple diseases can mimic cysticercosis or tuberculosis or brain tumors, whatever. Neither do our criteria, except for the solitary form, except for those who present with seizures. But if they have other forms in other locations, you need a serological test. And that's where the real story of collaboration with the basic scientist starts. I approached the microbiology department. They were very busy. They said, we can't take on another test. That was in 1992 or 93. There was no commercially available kit available. And ELISA was the best. EITB, which the CDC had developed in 89, they had not rolled out the commercial version. I approached Professor Anna Uman in neurochemistry, and she asked me one question. Is it something that is very important to patients here? I said, yes. We see at least 2 to 3 patients with this disease every day. So she said, I put up a hand. I'll try to do. I'm not an immune biologist or immunobiologist or whatever. My area is in protein chemistry, but I will help. I will learn. So with us, but the thing is, imagine in 1996, we didn't have 60,000 rupees to buy her get her an airfare to CDC. CDC said, we'll help you develop the test, but we can't fund her. Stay. So I approached Professor Abraham Joseph, who was the head of the department in community medicine, because I said this disease is out there in the community 100%. So we need community medicine involvement. He said, let me search for funds. Very difficult. And he put me in touch with Danida, with whom he was working on something else. And they gave us 1.2 lakhs. With that, we sent Anna Uman for 2 weeks to CDC. She came back, and sure enough, within a year, she could hire one a lab technician, and she developed this homegrown EITB. Again, very disappointing results with the solitary form of the disease. Here you see only 62%, but we were on our way. We had a EITB test in-house, which those days used to cost 125 rupees. Even now it costs only 500 rupees. And we even improved on that test. Prabhakaran, I think is, yeah, there he is. This is what we published using urea. I'm not an expert in this, and something about exposing the antigens better, whatever. And we were able to improve the test by 46%. That means patients in whom the test is negative with the routine EITB, once you use 5 molar urea, you get better results. You can see these bands. This is the with no urea, and these two are with urea, and you see that the bands are more apparent. This is what I understood. You people will be better at this, reading this. But it was just not of use only in the lab or some unusual cases sometimes. Here is a child who was helped with the availability of this test. This is a 9-year-old girl who presented with seizures and nothing else. You have this quite a big lesion. It measured more than our diagnostic criteria, 22 millimeters. And this is in a part of the brain called the insula, left side. Left side is the dominant part of the brain. So you don't want to meddle with that. We don't want to biopsy it. We don't want to go there. We don't know what it is. Is it tuberculoma? Because it's more than 20? I don't know. A lot of edema. You see, the edema is this black stuff. A lot of edema. But the EITB was positive. So I said, let us treat with albendazole. So this is a few months later. Patient is better. The granuloma is smaller. And that after 18 months has become a small calcific dot. So this patient avoided surgery, avoided empiric antituberculous therapy because of the availability of the EIT. Soon enough, we went on to elaborate, talk about, publish a lot of different aspects of cysticercosis and tell the world about how to manage, how these patients present, so on and so forth. I won't go into details of that, but I'll talk about this one particular study that Professor Geeta Chako did. What we were finding was in those patients in whom we biopsied, we had almost stopped biopsying these lesions because it's not necessary. They resolve spontaneously, but occasionally we had to biopsy. We were not finding the parasite in a lot of them. In about 50% of the patients, no parasite. Just a granuloma, not necrotizing, not caseous, no Langerhans, not tuberculoma, but we can't put an etiological label on it. So she studied them very carefully and found these calcified vacuoles, not in every patient, but in quite a few, these black dots that you can see around. And these are actually parts of the parasite that calcify. And they are a marker for cysticercosis. So this was an interesting paper with pathology. I will talk briefly about the major clinical papers. One is the rate of spontaneous resolution, because it was believed at that time that in 3 months, all these lesions disappear. We realized that it is not so simple. The solitary cysticercosis granuloma does not know that it has to disappear in 3 months. Its biology is varied. So we said, it's not so simple, because what people believed was if it doesn't disappear in 3 months, it's not cysticercosis, you have to treat the antituberculous. So we studied this in a prospective study of 210 patients, and we found that at 3 months, actually only 20% resolved completely. And even by 2 years, 90% resolved, but 10% still didn't. And this is illustrative of that. 3 months, complete resolution of this. At 12 months, it's still there. It's not only there, it's become larger. And at 15 months, again, it's still there, smaller, but still. So we documented the varied natural history of solitary cysticercosis. And this is a much longer duration study, trying to answer the question, how long do these people require anti-epileptic drugs? Because what happens is these patients just have one flurry of seizures. You give them anti-epileptic drugs, they'll never have seizures again. So the typical teaching in neurology is wait for 2 or 3 years after the last seizure to stop anti-epileptic drugs. Do these patients require it, especially when the lesion has gone on the CT scan? Nobody knew the answer. People were continuing to give for 2 to 3 years, especially the neurologists believed. So we said, no, we started practicing withdrawal of anti-epileptics as soon as the lesion is gone. And what does that result in as far as the recurrence of seizures? This is what we found. We followed these patients for 2 to 10 years. See, there are no shortcuts in life. Everything takes time. If you want to enjoy good wine, I'm not a great wine drinker or so, but I'm told aged wine is the best. Something that is being kept in the cask for a long time, a wooden cask, keep deep in the basement. So keep working at it. 10 years we followed up these patients and we found that 85% of these patients were seizure free. 15% had recurrence. Now we need to say, so should everybody be treated with anti-epileptic drugs for 10 years or whatever? No, you need to identify what were the factors associated with recurrence. And we did find calcification. Yes, you see the Kaplan-Meier survival curve. That is without calcification. This is with calcification. This is proportion without recurrent seizure. So as you go along, the patients with calcification have a higher chance of recurrence. So we know patients with calcification, don't be in a hurry to withdraw antiepileptics. Those who have seizures at follow-up or what are called as breakthrough seizures, and those who have more than seizures. Other than these patients with these risk factors, the others you can withdraw as soon as the lesion is resolved on the scan. But we were actually poking at the tip of the iceberg. We were looking at patients who are coming to our hospital. We needed to know what happens in the community. And we were fortunate to get this task force grant from ICMR. And that is Professor J.P. Mulial, head of the Department of Community Medicine at that time. So I went to him and I said, we need to study this in the community. And this is, to my knowledge, the largest community study of cysticercosis anywhere in the world. We studied more than 50,000 subjects with a door-to-door survey to look for active epilepsy. And anybody diagnosed with active epilepsy was asked to get a CT scan. Out of 200 odd patients, 188 or 87 agreed for it. And in 1/3 of those patients, we found evidence of cysticercosis. So this number has been borne out in study after study, not only from India, from all over the world, South America, Sub-Saharan Africa. 1/3 is the number of patients with active epilepsy in whom the cause is cysticercosis. And even more worrying was 15% of the people in Vellore districts. So if there are 100 of us here, 15 of us have been exposed to the larval antigens. And by the way, one important thing I want to clarify, you don't have to be a pork eater to get cysticercosis. I'm a vegetarian, I can get cysticercosis. A lot of patients are vegetarians, even Muslims. So any one of us can get cysticercosis. We don't have to be pork eaters. That's a big misconception, a big myth that you have to be a pork eater to get. No, you have to be a pork eater to get teniasis. If you are a vegetarian and if you got teniasis, you're not telling the truth. Okay, so something is not right. So vegetarians and devout Muslims, devout Jews do not get teniasis. Okay, so 15% of the population is exposed to larval antigen. That's the kind of contamination we have of our food and water. And soon enough, after the task force grant was over, we were fortunate to get funded for 4 years by the Flemish Inter-University Council called VLIR, VLIR. And this is a group in Belgium that worked with us with, again, another group in Nepal. And we did a series of studies in the community. And that's, by the way, pork being sold in Vellore. Just a few years ago, I don't know whether it's still like that, under a tree. I mean, I don't know if most of you know that there is no licensed shop to sell pork in most of Vellore. Most of pork sold is under the tree on Sundays. Okay, and this is the kind of meat you may get. people from, I think Prabhakaran might have also gone to these informal shops to buy to harvest all those larvae for our antigens to run the EITB test. And this is a group of workers trying to get a blood sample from pig because we studied porcine cysticercosis in Vellore district. Okay, it takes a lot of people, as you can see, 4 or 5 to sort of handle a big pig. They're quite fierce, and they sort of are not easy to take blood from. But we did a lot of studies, including teniasis and so on and so forth. We also studied the disease with collaborators in Nepal. This is Durgadat Joshi. This is way back. See that's a young me. 2002, more than 20 odd years ago. This led to also studies in the labs. As we were studying the disease in the community, we were also studying disease in the lab. So the disease in the lab. So this is a very interesting study I want to talk about, again funded by the Prabhakaran senior. Is he senior to you, Jayaraman, or I don't know, junior to you, sorry. So he was the person who did this study with, and this is Dr. Anna Woman's idea. She said, let us look at all the immunological parameters. So I hope I can convey to you what the meaning of these findings are. See, what we are studying when we are saying serological test is the antibody to the Taenia solium larval antigen. Okay, that's what causes the disease. Cysticercosis is the larva. So larval antigens, we want to look for antibodies. That is here. That is 15.9%. I told you, this is in the community. But this is something that people haven't studied. This is IgG antibodies in the blood to Taenia ova. That is the shed eggs in the stools that humans are not supposed to consume. Okay, but look at the prevalence, 41.1%. Okay, that is the amount of exposure. That is almost 1 in 2 of us is exposed to the ova in our food or water. But only 15.9% develop into larvae, or at least the body reacts to that and develops antibodies. And we also studied Taenia solium cysticercosis antigens in the serum, not antibodies, antigens, which tell you that there is active disease. That comes down to even less, 4.5% only. The rest are only exposure. 15% is exposure. That's antibodies. Disease comes, the exposure happens, it doesn't establish in your body. Probably it's washed away, whatever. But look at the amount who develop seizures, even very, very small percentages, even much, much lower. And finally, look at the number of people who have teniasis in the community, less than 1%. So you just require 1 in 100 people to have teniasis to produce this kind of havoc. You don't need too many people to have teniasis in the community. And it's not easy to diagnose teniasis. So this is something which was very interesting. I thought I'll just sort of share with you. We realized through several studies that, EITB is not perfect. That I told you earlier, only 60% sensitivity, and even lower when it comes to calcification, 1/3 only. And even with multiple lesions, GMNCC is multiple. Granulomas in the brain, it's only 80 odd %. So we had hit a brick wall. We needed to move to something else. And there are many challenges which are sort of summarized in this slide. So we started looking at alternative options. Peripheral blood markers and serology. This is around 2011 or so. And that led to our first grant from the NIH. We changed track from antibodies, antigens to something more sophisticated. And I remember Anna Woman being very excited when she heard the term MS. She said, mass spec is the way to go. It's very exciting. This is about 15 years ago. It just sort of coming out. We didn't have the MS at that time. And so we said we will study it both with genomics and proteomics. These are the collaborators from Oklahoma University, Helene, Doug, and the late Jay Hannes. We started off with a NIH DBT grant. It's called R21 for 3 years. And then follow-up grant RO1. That was a small grant. That was only some $250,000. And then this is the $3 million. So our aim was to try and see with this kind of an approach, whether we can eliminate CT and MRI from the diagnosis of cysticercosis. Of course, we didn't succeed because it's a very complex disease. Anyway, I'll share with you some of the studies. So this is the first paper that came out. I think Prabhakaran is the first author in PLOS NTD. It was interesting to see that when we did microarray, we found 15 genes in mRNA from monocytes. We found 15 genes which were specific to cysticercosis, patients with cysticercosis and seizures or epilepsy. And they could separate out patients with cysticercosis and epilepsy from other causes of epilepsy, like idiopathic epilepsy. The one sort of slip up was we didn't study tuberculosis, because tuberculosis and cysticercosis share inflammation in the brain. We didn't do that. That was an error, but the amount of money we had was very small. That time it was $250,000, not enough to go around. So we said we will fix that in the subsequent grant if we get it, and we did. And these genes were related to whatever GTP related immune, neural process, and so on. Again, I'm just a neurosurgeon. I am not very comfortable or familiar with these terminologies. I just want to show you what we did. So these are the NCC related genes, 14 of them. I don't know why one was dropped. Prabhakaran, do you remember why from 15 we came down to 14?
So that is all is a pseudo.
It's a pseudo. Okay, there you go. See, I didn't know that. I'm working with him for 15 years. That was a pseudo gene. Okay. So initial paper said 15, but then we went on to 14. And these are the 14 genes that we've been working with in the subsequent study. And this was from the mass spec study, the first study, R21. And you can see that it was very exciting to see that this is NCC, the squares, and these bars are epilepsy of unknown etiology. As a group, at least, they were nicely separated out with the mass spec serum profiles. This is SCG versus this is on circles are SCG and these are calcification. So even within neurocysticercosis, the different categories were separated out through mass spec. This is multiple and this is solitary. So we were very excited about this, but I was told that don't get too excited. To get a test out of this is a long way off. Okay, something about qPCR you have to develop and so on and so forth. So when we were doing the R01 grant, I realized that we were sort of not really making very much progress in just separating out whole of cysticercosis from whole of non-cysticercosis pathologies causing seizures. So I said, let us go back to the old problem, tuberculoma versus cysticercosis. So here you have, see, these are lesions which are radiologists called tuberculomas. All cysticercosis, by the way, on top. How do I know? They resolve spontaneously or with albendazole, not anti-tuberculous therapy. Again, this is NCC and this is tuberculoma. Very difficult to separate out. So we said, let us just study this specific problem. And we did find that out of those 14 genes, there were 3 genes, these 3, TAX1BP1, RAP1A, and GBP, whatever. These 3 had a very high specificity. They were not seen in patients with tuberculomas, but if they were seen, not in everybody, you see that it was not seen in everyone. These 5 were negative, but taken together, 90% or close to 90% sensitivity, but more important, specificity, 100. So if one of them is present, then it's unlikely to be a tuberculoma. So this was published in Open Forum Infectious Diseases a few years ago. And we also said, hey, we say that these genes are associated with inflammation. So if the inflammation dies down on the imaging, and the markers of inflammation on imaging are edema and enhancement. This is enhancement. This is an MRI image with enhancement, and this black is edema. So here you have patients in whom the granuloma is resolved. Here calcified, that's black is calcification, and this here it is persistent. So these are the three outcomes of solitary cysticercosis. Once the enhancement goes away, edema goes away, what happens to these genes? Do they also reverse back? And in fact, we found that 3 of those genes did go back, come down. At presentation, this was their, these are the levels, mean levels, and this is at follow-up, statistically significant. So we studied them prospectively. At presentation, what was their mRNA profile in the monocytes, and what was their mRNA profile at follow-up with imaging correlates. And this was again published in 2021. And I told you, remember, that calcification is a bad prognostic indicator for outcome as far as seizures are concerned. So is there a way to say that these solitary cysticercosis granulomas will go on to calcify? Till now, we don't have a marker. We don't know which patient with a solitary cysticercosis granuloma will go on to calcify. 20%, by the way, go on to calcify. 1 in 5 goes on to calcify. Who will calcify? Who will not? We have no way to know. So we said, let us study that. And this, we said, we will study again in a prospective manner. And we found that there are some serum proteins. This is on MSMS. Some serum proteins, these 2 ECM1 and MST1, which had again 100% sensitivity in predicting calcification. So this is very exciting. This needs to be, of course, this is a very small sample size, 20, needs to be studied further. But if it is true, if you just study these proteins at presentation, you can tell the patient, you can't do much about it. You need to evolve some management strategies to avoid that calcification, of course. But at least you have now a target population. These are the people whom you need to give that therapy to avoid calcification. This is again a paper from the that MSMS work by Jay Hannes. I think this is one of the last papers before he passed away, unfortunately. And these are that IPA and so on and so forth. But again, it shows you that solitary cysticercosis granuloma from idiopathic epilepsy are clearly separated out as a cohort, not in individual patients. Again, this is not that you can take one patient and take the blood and say, oh, if your MS profile is this, you have solitary cysticercosis granuloma. No, it's in a cohort. But this is something, again, very exciting. This is one of the last few papers. We said, see, we were looking for larval antigens and 5% whatever. Is it possible with MS, which is much more powerful tool, I'm told, to look at proteins and peptides, that we can find small traces of the parasite in the blood of patients with neurocysticercosis? So we found that 90% of patients had tinea solium protein 312. But interestingly, even non-NCC patients from the community, an endemic region, also had much lower number, but they had 15 T solium proteins, and there is the overlap. 8 are overlap. So this is very interesting, that you are actually finding the parasite proteins. These are parasite proteins, non-human proteins in the serum using this powerful tool. So I'm coming to the end of my talk. Besides all that exciting work, what it has led to is that our work has been recognized by WHO, FAO, and so on and so forth. And we have been part of several guideline development groups in WHO and other kind of major institutions like the IDSA, Infectious Disease Society of America. And so I want to summarize what 40 years of work has led to. What I'm most sort of happy about is the fact that, yeah, 74 publications is great. It's very nice. Is the fact that our work has been recognized. Now, if you talk about cysticercosis in India, CMC is very much on the map. We are virtually invited to any international meeting that is held to develop management guidelines or whatever. And this actually is the just published last month. This probably will be my last paper on cysticercosis. Just recently published again with collaborators from all over the world, some books which we published. So I want to basically end by acknowledging a lot of people, funding agencies, collaborators from across the world, and of course in India. So it's not only the funding agencies and institutions, but of course there are people. I think there are about 30 people here. There are many more who need to be acknowledged, but lack of space and time prevents me from doing that. And finally, these are the people who have been collaborating with us in our department over the last 15 years or so. Some of them you recognize. This group from Oklahoma University, and Helen has moved to, there's Helen there. Helen has moved to University of Montreal in Canada some 10 or 8 years ago, halfway through the R01 grant. She moved there, but she's very much still part of our team, still very much helps us with so many things. A lot of exciting things still going on. Ranjit and Prabhakaran have now taken the lead, and I look forward to seeing much more exciting work from the department in the years to come. So I will end there and will be happy to take any questions that you may have. And I once again thank Nihal for the opportunity. Nihal, thank you so much for giving me a platform to share this. I've never had the opportunity to share the whole story at one go. I'm sorry to have kept you so long. Thank you for your patient hearing. Thank you.
We can have questions from the audience over here as well as online. This is a very has been a fantastic opportunity to hear. It's very rare achievement and very fascinating story. And I hope all the online people are also here. Any questions, please come forward. You can unmute on your own and go ahead with the questions.
Yeah. Hello, sir.
Yes.
Yeah. Hello, sir. This is Amit again. Nice to hear you. Fantastic talk.
Thank you.
I would like to know your opinion about the asymptomatic neurocysticercosis. What was the prevalence when you did the community survey, and what is your opinion about it?
That's a very important question, Amit. Yeah. So, as you know, the rate of asymptomatic neurocysticercosis has been talked about from the 60s based on the autopsy studies. Basically, when you do an autopsy and in a person who has not known to have had seizures in their lifetime, the rate was about 2%. That is picking up calcifications in the brain. And we now, of course, have the opportunity to study that through imaging. And I would suspect that's the same number. But you remember that we did not do CT scans in people who are asymptomatic. That would not be ethically correct. We have been asked about this before also. I don't think we should expose anybody who's asymptomatic to radiation. CT scan, after all, has some amount of radiation. So we never did that. So we don't have a number for that. But I can tell you that patient comes with head injury, you do a CT scan, you find calcifications, and patient never had seizure. You have a patient with brain tumor, you have calcifications in some other part of the body and some other part of the brain, and they tell you they never had seizures before the one related to the tumor also. So asymptomatic neurocysticercosis is highly prevalent because not every larva that goes and lodges in the brain causes seizures. It goes to so-called silent areas of the brain, which are not epileptogenic, far away somewhere, right in the frontal lobe or some other part of the brain. So I don't have a number for that from the community because we never studied ethical reasons.
Okay. Thank you, sir.
Rajshekhar,
Yeah.
fantastic work.
Oh, thank you, Doctor. Thank you.
Yeah. So my question is, with 15% of the community having antibodies or whatever marker you're using, do you think it's worthwhile to try a small-scale trial with albendazole just to the whole community to see if this will decrease the incidence?
Yeah, it's a very interesting question. So just want to clarify one thing, Anindo, that 15% is the exposure to the larval antigen. That doesn't mean disease. It is just exposure. So as far as mass MDA, mass drug administration is concerned, that has been tried actually to try to reduce or control neurocysticercosis in the community as a whole. And that's been tried in northern Peru through a grant from the Gates Foundation. So I went to evaluate that. But the problem is you need to do multiple cycles because people from the neighboring districts or wherever, they come in who have not been
Vivek.
And they keep getting they keep manifesting, or they infect others with teniasis and so on and so forth. So MDA is used not to treat the patients with neurocysticercosis. MDA is used to treat people with teniasis.
I know.
Teniasis. So basically, we don't use albendazole, we use niclosamide. Niclosamide, one dose of niclosamide. And I went for the evaluation actually in Peru. I went to the trial site, and interestingly, after some 3 or 4 or 5 cycles of this MDA, they did bring it down, but could not eliminate it. Could not eliminate cysticercosis. So basically, there's a very easy way to eliminate cysticercosis in the community. Swachh Bharat Abhiyan. Let everybody use latrines, which the Department of Community Medicine, if you remember, right, way back in 1975, told us that it's something that we don't need to reinvent the wheel. We know about it, but long way to go.
And the second question is more pathological, which is, it's kind of unusual for a granuloma to regress on its own. Does that ever happen with tuberculomas, or is
Not
this
to my
something new? So why does it happen? Why does it happen in cysticercosis? What's going on that it just totally disappears into space?
That's a very good question, and I don't have a good answer for that, except to sort of speculate that you remember that the granuloma that forms around a dying larva or cysticercus it's dying basically, whereas in a tuberculoma, although it's a paucibacillary disease, the CNS tuberculosis is paucibacillary. Only 1/4 of patients with brain tuberculoma have acid-fast bacilli either in their histological examination or on culture studies. So this still is something active. May not be the whole bacteria, but there is something that is still provoking a response from the host. Whereas for the cysticercus, it's dying. It's dying. So once the host immune response has sort of walled it off, there's no active sort of parasite antigens. It's dying on its own. That's the natural history of the parasite. The parasite is not meant to be in the brain. It's supposed to be in the gut. So this is the only sort of explanation I can give. But you're absolutely right. Tuberculomas don't resolve spontaneously.
Does the disappearance of cysticercosis granuloma in the skin also happen, or is this unique to the brain?
Very interesting question. I think we need to ask the dermatologist, but I have never come across that. But by the way, they do die. They do die because you get what are called as cigar-shaped calcifications in the muscles. Muscles, they do go on to die and calcify. So that I know. Subcutaneous, I suspect, would also do the same, but muscles, they go on to die. Yeah, they do not resolve, but some will resolve, I guess. Some go on to calcify.
Thank you. That's beautiful work. Congratulations.
Thank you.
Hi, Raj.
Oh, Mathew's phone. Is that? Is it?
Hello, Raj.
Is it?
Can you hear me, Raj?
Oh, yeah. Yes, sir. Yes, sir. Okay. Yeah.
This
Hello.
is Mathew Chandy.
Yes, sir. Please go ahead.
First time I'm hearing the whole work myself.
Yes.
Thank you for that and congratulations.
Thank you, sir. You were very much part of it. I'm sure you remember all that in the early days. And thank you for all your encouragement and the push for me to apply for an ICMR grant as a neurosurgeon. I sort of never imagined that a neurosurgeon should be applying for ICMR grants, but you pushed me to it, and that's what has led to all this. So thank you for everything that you have done for me.
There is a part of collaboration. There is a part of collaboration which I must mention, and that is that it's not very often that the head of a department or the unit picks a younger, smart, upcoming neurosurgeon and gives him the whole problem to write about, to think about, and to solve. I think that itself is something, looking around, I think that is pretty unique.
You're absolutely right, and I thank you for that. And I think there is a lesson in that for the senior faculty in
Yes.
the institution.
Yeah. Please mention that.
No, absolutely. No question about that.
No, I said please mention the fact that there is a lesson
Yeah, absolutely.
for senior people in the institution.
Absolutely, I agree. But I mean, I don't mean to sort of downplay the message, but I think it's a two-way street. The younger person also should take up the baton that is handed over.
Of course.
Yes.
Of course.
No, thank you once again for all.
Raj, can I make one comment?
Hi, Raj Narayan. Yeah,
Hi, Raj.
Yes, this is
Good to see
Raj
you.
Narayan. I'm calling from New York. I've always been your biggest fan, and I stayed up till midnight to listen to your talk.
I know. Thank you.
So I just wanted to say this is such a wonderful example of a lifelong, a career-long effort to solve a problem. Dr. Jacob Abraham used to say, when if you can make one small mark on the field, then you've accomplished something. And I always thought that that was sort of an underachiever type of sentiment. But now as I get towards the end of my career, I realize that making a mark on anything is a very difficult thing. And you have certainly made your mark on this. Congratulations.
Thank you, Raj.
Thank you, sir, for that very, very inspiring, extensive body of work. My question is, in fact, totally unrelated to specialty in many more ways than one. But
You are related.
well,
Yes.
those who know me perhaps you know. But I think from the perspective of parasites brain, from my very eager knowledge, there are only 3 parasites which actually house themselves in the brain in a big way. One is this, of course, Neurocysticercosis, and then toxoplasma, and maybe to some extent malaria, but maybe the
Schistosome.
That
is not for us, but you're right. Malaria.
The number of, whatever filariform, rapidiform larvae floating around the place. Why is it so specific that mainly this one isn't? Maybe there are some parasitologists online who might be able to answer that question as well.
We really don't know what the tissue affinity is. Why? And it's of all the organs, why not the heart muscle, for example? It goes to the skeletal muscles, but it doesn't go to the cardiac muscle. Generally, means there are a few case reports, but Why doesn't it, even the liver, for example, everything from the gut goes through the liver, but very occasionally only you get a tinea, or I mean a cysticercosis in the liver. So these are unresolved. Or again, the pulmonary filter. Why is it that it likes the brain so much? Eyes, of course, eyes can be considered part of the brain. Eyes, the brain, the subcutaneous tissues, and the muscles. These are the 4 target organs for it. And I really don't have an answer for that. Means I haven't looked into it at all. But like you said, probably it's for the basic scientists to really try and find out. There are many, many unresolved questions actually that we need to answer. But I think the most important sort of work now is to make sure that we don't have to study this disease, to get rid of it. We don't need to be, doing all sorts of this basic high fundamental kind of research for something that can be eliminated.
Okay, are there any further questions from the audience? We're coming to 9:30, 1 hour is over. Any other questions, or we can it is my honor and it's been a pleasure, and I far beyond whatever I had imagined. 40 years of work, sir. Thank you so much for giving and inspiring us to do further. And thank you, Dr. Nihal, and the Central Center for having this opportunity.
Thank you.